So it usually happens in like a brightly lit, overly air-conditioned doctor's office, right? You
Yeah.
get handed a piece of paper or...
Or you just open the patient app on your phone.
Right, exactly. You open the app to look at your test results and bam, you were immediately confronted with this absolute wall of words that look, well, completely alien.
Oh, yeah. Just words with 20 letters, these strange consonant clusters.
Yeah, and they have this vaguely ancient sound to them, It feels like you need to be fluent in a dead language just to understand what is actually happening inside your own body.
It really does. It's incredibly intimidating for most people.
It is. But the promise of our deep dive today is that you don't actually need to memorize tens of thousands of complex medical words. There is basically a kind of source code, a hidden architecture that lets you decode almost any medical term on site.
Yeah, it functions almost like a programming language for human anatomy.
Yeah.
And the brilliant thing is, it operates as a highly logical, closed system.
Which is exactly what we are looking at today. We've got a great stack of sources that break down how this massive linguistic system operates, not as a random dictionary, but as this incredibly precise, engineered code.
But exploring how this ancient, durable system works is really only half the story here, because we also need to understand the unintended consequences of this architecture.
Right. The real-world impact.
Exactly. This very system is currently at the center of some fierce ethical and linguistic debates in modern medicine. It's this constant balancing act between clinician precision, patient safety, and modern technology.
Okay, let's unpack this. Because to understand those debates, we really first need to look at how the system is built. And the core concept here is all about combinatorial efficiency.
It's a great way to put it.
The sources describe medical terminology as essentially a closed set of Lego-like word parts. You have roots, prefixes, and suffixes. And once you know, say, a few hundred of these basic blocks, you can build or deconstruct thousands of terms.
Right, so the mechanics basically rely on those three primary building blocks. First, you have the root, which holds the core meaning of the word. It usually designates a body part, a substance, or maybe a color.
Okay, give me an example.
So the root cardi means heart, hepat means liver, set means cell. That establishes the foundation of whatever it is you are discussing.
Got it.
Then you have the prefix, which is attached to the front of the root. And prefixes modify that root by indicating location, time, amount, or negation. For instance, peri means around, tashi means fast, Brady means slow.
Now, the relationship between the prefix and the root is where people often get tripped up, I think, because they assume they're just interchangeable pieces.
Yeah, they really aren't.
Right. So a good analogy from the sources is that structurally, the root is the noun. It's the house. The prefix is just the address or maybe the weather happening around the house.
Oh, I like that. The weather around the house.
Yeah. So cardi is always the physical heart. But adding peri to make pericardial just tells us we are talking about the area around the heart. Or tachycardia tells us the heart is beating fast. The prefix never becomes the core subject itself.
Exactly. And then you add the final piece, right? The suffix, which attaches to the end of the root to indicate a condition, a procedure, or a disease state.
Like sumpeditis for inflammation.
Spot on. The suffix iditis means inflammation, and aditectomy means surgical removal. But to actually connect these pieces into a word you can pronounce, the system relies on this crucial mechanism.
The golden rule of O.
Yes, the combining vowel, which is almost always the letter O. I mean, roots rarely appear completely bare in speech, right? They are chained together using this vowel.
And the rule for using that O resolves almost all the spelling confusion that students face when they're first learning this. Yeah. You use the combining vowel O between two consonants, but you drop it when the next word part starts with the vowel.
Right. So if we take the root for joint, which is Arthur, and we want to indicate inflammation of the joint, we add the suffix iritis.
Because athitis starts with a vowel, the I.
Exactly. The rule dictates we drop the O. The term becomes arthritis. You don't say arthrotis.
That just sounds weird.
It would. But conversely, if you want to indicate the procedure of viewing a joint, you use the suffix roscopy. Since arthroscopy starts with an S, which is a consonant, the O remains. The term is arthroscopy.
It's so cool. The modularity is incredibly satisfying when you start chaining multiple roots together. Look at the word electrocardiogram. You take elector, meaning electricity, link it with an O to cardi, meaning heart, link that with another O to the suffix lassigram, meaning a recording.
A recording of the heart's electrical activity.
Boom. And Willem Einthoven actually constructed that specific term when he developed the string galvanometer ECG back in 1903. He built the machine, and then he just snapped the literal linguistic blocks together to describe exactly what it did.
And the clinical precision that this stacking allows is just profound. Consider a term like osteoarthritis.
Okay, let's break that one down.
You have osteo for bone, arth for joint, and the aditis for inflammation. It literally translates to inflammation of the bone and joint.
Which is way more specific than just saying arthritis.
Vastly more specific. Because osteoarthritis denotes the pathology of bone degeneration beneath the cartilage, rather than an issue isolated to just the joint capsule itself. The word literally contains the diagnosis.
Now, that kind of precision really implies a deliberate design. But there wasn't a single governing body that sat down and engineered this grammar from scratch.
No, not at all.
The blueprints for this system evolved over 2 millennia, creating this massive, layered history.
Yeah, the timeline begins roughly 2,400 years ago with Hippocrates of Kos. Writing in Greek, he coined foundational terms that remain in active clinical use today, words like arthritis, diarrhea, and coma.
And Hippocrates coining those terms implies a massive philosophical shift in medicine at the time. I mean, he and his followers were actively pushing back against the prevailing idea that illness was a divine punishment or some mystical event.
Right, they wanted to treat diseases as natural phenomena.
Exactly. So they desperately needed a standardized vocabulary to describe what they were actually observing in the physical body.
And that need for observational language laid the Greek foundation. Then, the second major layer was added by Galen of Pergamon in the 2nd century.
Roman connection.
Yeah. As a Greek-speaking physician to Roman emperors, Galen's prolific writings essentially cemented this Greek medical vocabulary within the vast administrative networks of the Latin-speaking Roman Empire.
But the survival of this system wasn't just a straight line through Europe. I mean, after the fall of the Western Roman Empire, that Greco-Latin knowledge base heavily relied on the Islamic Golden Age for its preservation.
Yes, the translation movement during the Islamic Golden Age was an intellectual bridge of staggering importance. Scholars like Ibn Sina,
Better known in the West as Avicenna, right?
exactly Avicenna, they didn't just passively store these texts, they translated Greek and Syriac medical works into Arabic and synthesized them with their own clinical observations. Avicenna's monumental work, The Canon of Medicine, vastly expanded the pharmacological and anatomical vocabulary.
Which was then later translated back into Latin during the 12th and 13th centuries.
Yes, reintroducing and enriching the terminology in Europe.
Which brings us to the Renaissance anatomists, like Andreas Vesalius in the 1500s. He takes this inherited, translated text and starts grounding it in actual human dissection, because Galen had largely been forced to rely on dissecting animals.
Right, human dissection was taboo for Galen.
So Vesalius starts pinning specific Latin descriptive names to the exact human structures he is actually mapping out.
And by doing so, Vesalius firmly establishes Latin as the dominant language of anatomical structure, while Greek remained heavily utilized for clinical conditions and pathologies.
Wait, so we have Greek, Latin, and Arabic all swirling around over centuries. Wasn't this incredibly chaotic for doctors trying to talk to each other across borders?
Oh, it created a massive crisis. By the late 19th century, anatomists in different European countries were assigning completely different Latin and Greek names to the exact same bodily structures.
Wow.
The medical literature was fracturing. A doctor in Vienna might use a completely different term for a nerve than a doctor in London.
And that international chaos forced the creation of the Basel Nomina Anatomica in 1895. It was the first massive attempt to standardize Latin anatomical nomenclature across borders. It's actually the direct ancestor to the Terminologia Anatomica we use today.
But what's fascinating here is that achieving that standard sparked intense linguistic infighting. The late 19th century hosted what linguists call the Purist Wars.
The Purist Wars, I love that.
Yeah, classicist physicians were deeply offended by the idea of combining Greek and Latin roots within a single word. They viewed these hybrid words as pure linguistic barbarism. The purist doctrine argued that a Latin root must only take Latin affixes, and a Greek root must only take Greek affixes.
But usage ultimately bulldozed that kind of strict linguistic segregation. You see it perfectly in a word like appendicitis. It is an incredibly common diagnosis today, but structurally, it's exactly the kind of hybrid those classicists hated.
Because it welds a Latin noun, appendix, directly to a Greek suffix, the velatus.
Right. The medical community cared about whether the word was useful and universally understood. not whether it respected ancient grammatical boundaries.
And the system survived because it prioritized utility over purity. It is a living, messy, hybrid tool. But we have to acknowledge that that same organic evolution has also baked in some severe structural flaws.
Yeah, let's talk about that.
The elegance of the combinatorial system on paper often masks its functional dangers in a high-stress clinical environment.
The acoustic ambiguity in this system is absolutely terrifying. Because it was developed over centuries in written texts, it is highly optimized for reading, not for speaking.
It's a visual language, yeah.
The sources highlight the difference between ilium and ilium. Ilium, spelled with an I, is the large flared bone of the pelvis. Ilium, spelled with an E, is the final section of the small intestine.
And spoken out loud during a fast-paced shift handoff or in a noisy emergency room, they sound absolutely identical.
Completely identical.
And that single vowel difference has caused documented surgical site errors and documentation failures. When an orthopedic surgeon and a gastroenterologist are collaborating on a complex trauma case, confusing the pelvic bone with the intestinal tract because of a shared pronunciation is a catastrophic failure of the terminology.
The system's written precision actively creates verbal hazards, and the affixes have the exact same problem. The suffixes, drumomy, toinivectomy, and ostomy sound incredibly similar if you're speaking quickly.
Oh, absolutely.
But clinically, the difference between them is the difference between life and death. You know, the otomy means cutting into a structure. An ostomy means cutting it out completely. An ostomy means creating a permanent opening in it.
Think about a tracheotomy. It's an emergency incision to open the windpipe. A tracheectomy is the complete surgical removal of the windpipe.
Wow.
A verbal mix-up between those two terms changes a chart from indicating a temporary airway procedure to a permanent, life-altering anatomical removal. This acoustic fragility is exactly why modern clinical documentation standards require such rigid, often redundant verification protocols.
But the spoken vowel isn't the only structural failure. The system actively breaks its own rules when it uses people's names instead of descriptive roots. Eponyms.
Right, eponyms. Diseases or conditions named after the physician who first described them.
Right, which has been standard practice for over a century. Conditions like Parkinson's disease or Down syndrome. But medical bodies are now aggressively moving to eradicate eponyms, and the most public reason is historical reckoning.
There are well-documented ethical imperatives driving this shift. For decades, a specific form of joint inflammation was known as Reiter's syndrome, named after Hans Reiter. However, when historical research definitively implicated Reiter as a Nazi medical official involved in horrific human experimentation, the medical community acted.
As they should.
Medical terminology boards formally dropped the eponym, renaming the condition reactive arthritis. A similar process is occurring with Asperger's syndrome as historical records tied its namesake to child euthanasia programs during the same era.
Here's where it gets really interesting, though. Removing those names corrects the historical record, yes, but it also fixes a massive functional flaw in the terminology itself. Eponyms are basically dead ends for deductive reasoning.
That's a great point.
If you tell a medical student a patient has Reiter's syndrome, the student has to rely on pure rote memorization to know what systems are failing. The name contains zero clinical data. It bypasses the entire root prefix-suffix architecture.
It breaks the code.
Exactly. But by renaming it reactive arthritis, the language suddenly works again. It tells the clinician exactly what is happening. Joint inflammation occurring as a reaction to an infection elsewhere in the body.
That functional correction is key. Every time an eponym is replaced by a morphological description, the system becomes more transparent for the clinician. But we also have to acknowledge that even the oldest, most established morphological roots carry their own strange historical baggage.
Oh, definitely.
The etymology of the word hysteria demonstrates how ancient medical folklore can basically masquerade as objective terminology.
The root there is hystera, which is the Greek word for uterus. But the way it was applied to pathology is just wild.
It really is. It stems from a literal Bronze Age medical belief that the uterus was an independent entity that could physically detach and wander throughout a woman's body.
Just floating around.
Yeah. Both Hippocrates and Galen endorsed variations of this theory. They believed that as the organ floated around, it put pressure on other systems, causing a vast array of physical and emotional symptoms.
A wandering organ, navigating the body like a ship, causing illnesses wherever it landed. I mean, it sounds completely absurd to modern ears.
Yet the resulting term, hysteria, was treated as a legitimate, objective medical condition for millennia. The etymology anchored the theory so deeply into the medical subconscious that it survived as an official psychiatric diagnosis until 1980. Yes. When the American Psychiatric Association finally removed it from the DSM, a piece of 2,400-year-old anatomical folklore shaped formal diagnostic categories well into the modern era simply because it was embedded in the Greco-Latin code.
Which really exposes the central tension of modern medical communication.
Yeah.
We had this 2,400-year-old system. It has massive acoustic flaws, it carries bizarre historical baggage, and it relies on a dead language.
Yeah.
For a clinician, the combinatorial efficiency is a powerful shorthand. But for a patient trying to understand their own diagnosis, this system acts as an opaque, terrifying barrier. And this is the core of the health literacy debate.
The clinical precision that doctors rely on directly conflicts with the patient's right to informed consent. I mean, if a patient cannot comprehend the words used to describe their condition, they cannot meaningfully consent to treatment.
The sources use the example of idiopathic pulmonary fibrosis. Now, to a pulmonologist, that term is 4 precise puzzle pieces perfectly snapped together.
Right, let's look at the pieces.
Idio means personal or distinct. Polyinopathic refers to disease. Pulmonary means lung. And fibrosis indicates scarring. So the doctor instantly reads, scarring of the lung arising from an unknown spontaneous cause.
But to a patient sitting in an exam room, idiopathic pulmonary fibrosis just sounds like an intimidating wall of Latin. It induces panic rather than understanding.
Exactly.
But if we connect this to the bigger picture, health literacy advocates are not arguing that clinicians should abandon this terminology when speaking to each other.
Right, still useful.
The dense precision of idiopathic pulmonary fibrosis is absolutely necessary for medical literature and peer-to-peer communication. Instead, the demand is for parallel, plain language translation.
Meaning the system essentially has to operate in 2 languages simultaneously.
Exactly that. Patient portals, consent forms, discharge summaries, and hospital signage must translate these complex morphologies into accessible concepts. The burden of translation has to fall on the healthcare system, not on a terrified patient frantically searching a medical dictionary on their phone.
But just as the medical field is trying to translate this ancient code into plain English for patients, the architecture of modern technology is completely doubling down on the Greco-Latin roots.
It is.
This ancient system is currently the absolute backbone of modern health information technology and machine learning.
The integration between ancient grammar and modern computing is fascinating. Artificial intelligence programs used in electronic health records rely heavily on natural language processing, or NLP. When a doctor types a free text note into a patient's chart, the NLP algorithm has to read that unstructured text and convert it into structured data that a hospital's billing and tracking systems can actually understand.
And the way the AI parses that text is by using the exact same Lego blocks we've been discussing this whole time.
Yeah, it tokenizes the words.
Right. It breaks them down into their morphology. It identifies the root, the prefix, and the suffix, functionally reading the text the same way a first-year medical student does.
Because the Greco-Latin system is fundamentally modular, it is the perfect training data for machine learning. An NLP system can take a complex string of text, strip away the combining vowels, isolate the roots like Ost and Arthur, and instantly map those concepts onto massive modern ontological databases.
Like CINO-CT, or the International Classification of Diseases, the ICD-11.
Exactly.
The AI is essentially reverse engineering the basal nomina anatomica.
It translates a physician's shorthand into standardized digital codes, allowing hospitals to track disease outbreaks, manage billing, and analyze treatment efficacy on a global scale. These hyper-modern computational systems, the very cutting edge of health IT, are entirely dependent on the structural logic established by Greek and Roman physicians thousands of years ago.
The journey of this vocabulary is just incredible. It begins with Hippocrates demanding a language for natural observation. It survives the fall of Rome, gets preserved and expanded by Arabic scholars, is mapped onto human cadavers in the Renaissance, and weathers the purest wars of the 19th century.
It's quite a resume.
Right. We see its fatal acoustic flaws in the emergency room, we recognize the ethical imperative to strip away its eponyms, and now we find its modular roots powering the artificial intelligence that reads our digital health records. Medical terminology is this powerful, imperfect code built on 3 simple parts. Precision here isn't just an academic exercise. It is the literal foundation of patient safety.
It is a constantly evolving architecture carrying the weight of ancient history while driving modern technology. And observing how seamlessly natural language processing algorithms map this morphology into digital data leaves us with a pretty profound question about the future of medical education.
Oh, absolutely.
As artificial intelligence gets better at instantly translating complex clinical shorthand into both structured data for hospitals and plain English for patients, we really have to wonder how long this human linguistic requirement will last. Will the medical students of the next generation still need to spend hundreds of hours memorizing this 2,400-year-old Greco-Latin code? Or will technology finally make these roots and affixes invisible, silently running the translation for us behind the screens?
The idea that a 2,400-year linguistic run might eventually be quietly retired by an algorithm is a wild concept to consider. But until that day comes, I encourage you to look at the next medical term you encounter, whether it is printed on a prescription bottle or lingering on a diagnostic chart, not as an unpronounceable wall of text, but as a carefully engineered puzzle. Look for the root, find the prefix. You know how the source code works now? Go break down some Lego blocks.